Hello, good evening.
Good evening and welcome to First Aid Chats by Dr. G. I am Dr. Adana Grandison, a physician in Barbados and your hostess for this evening. First Aid Chats by Dr. G is a live podcast that provides listeners with the unique opportunity to not only hear complicated medical conditions explained, but also clarify any misunderstandings you may have about that condition. After all, a medically aware and educated patient is an empowered patient. And this evening, our episode is entitled You Are More Than Your Scars. And our guest is none other than Dr. Dale Springer. Dr. Dale Springer graduated from the University of the West Indies in 2003 and completed his postgraduate training in general surgery in 2014. Subsequent to this, Dr. Springer completed a 1 year clinical fellowship in breast and endocrine surgery at the first affiliated hospital in Shongwin Medical University. Dr. Dale Springer is a consultant, general, and breast surgeon at the Queen Elizabeth Hospital and lecturer in general surgery at the University of the West Indies. His areas of special interest are breast conserving surgery, triple negative breast cancer, and the genetics of breast cancer. Good evening and welcome, Dr. Springer.
Good evening, Dr. Grandison. Thank you for having me on your show.
Thank you. I hope everyone can hear me. We had a bit of a delay just now, but I hope everyone can hear me. Can everyone hear me? Excellent. Great. So, Dr. Springer, last week we actually had Dr. Alex Doyle. He joined us to speak about what's wrong with my breast, discussing both benign breast disease as well as starting to delve into malignant breast disease. And so this evening, I wanted to start off our discussion with a bit of a recap, with you highlighting what a surgeon would be looking for, a doctor would be looking for on examination that may cause you to think, or better yet, that on a patient's at home manual examination would cause them to think that there is the possibility of a mass that is malignant in the breast. I'll start the conversation there.
Yes, and your patients at home should be doing their breast exam, so it's a good point you brought up. When we see patients and we're examining the breast, we always start by looking at the two breasts and comparing them to see, are they the same, are they different in any way? When we're looking at problem areas or areas that might be a little worrying, is if there's any dimpling or retraction of the skin, or if there's any rashes to the breast, especially rashes to the nipple. Yes, or if the nipple is pulled in. I know some women normally will have a nipple that is retracted or pulled in, and they have it for all their life, so that's not worrying. But if it's something that is new onset, sometimes you can even see a lump, a visible lump, or there may be a break in the skin, what we call an ulcer to the skin. So all these are worrying signs just on looking at the breast. Then after we looking, we go into our examination and actually touching the breast. So if you feel a lump that is hard in the breast, that is fixed and not moving, that is concerning. And also you have lumps under the arm and in the armpit area, what we'll call medically the axilla. That will also be a little concerning. And these signs will suggest that you will need to have some further investigations done.
Okay, great. So you have found that lump in the breast. Walk us through the investigation process. Last week we spoke about mammography. We spoke about ultrasonography for the younger patients who may have very dense fibrous breasts, or even the postmenopausal female patient or male patient who may need further investigation. We started to speak a bit on biopsy and the different types of biopsy, but just walk us through that investigational process for us to confirm that breast cancer is present.
Right. So normally we'd start off, depending on the age of the patient. If the patient is over the age of 40, we'll want to do a mammogram and an ultrasound. If the patient is on the age of 40, we would go for an ultrasound. And in some cases, the mammogram, but definitely over the age of 40, we want to do a mammogram and the ultrasound. And The purpose is one, to confirm the lump that you have felt, to see the location of it, but more importantly, to see if there are any other lumps in the breast that you can't feel or you can't see, because this can help guide your management, and also in the other breasts, because what happens to one breast can also happen to the other breast, at maybe at an earlier stage. So we normally start with a mammogram and an ultrasound. In some young patients, and we're a little worried about if you have a genetic predisposition to breast cancer, we also do a breast MRI.
Mm-hmm. Mm-hmm.
After we've done these investigations, your ultrasound, your mammogram, and you'll confirm the lump that is there, the next step is a biopsy. And this is normally an outpatient procedure done under local anesthesia using a special biopsy needle, which we insert into the breast to take about 5 to 7 pieces of tissue from the lump to send to the lab for testing. When it goes to the lab, we test it to confirm. This really confirms for sure this is cancer when they look at it under the microscope. And it tells you what type of cancer it is. Then after that, we would like to go on and do some further testing to see what specific type of cancer. Is it hormone receptor positive or negative, or is it HER2 positive or negative? Is this a special type of breast cancer, which helps us to guide the management?
Okay. I saw in your research interests there was the mention of triple negative um, breast cancer. Can you just explain what that term means? Because we hear that term being tossed around quite a lot. And I just wanted to make sure that all of our listeners understand exactly what triple negative breast cancer. And then we have a question from one of our listeners.
Okay. So when you do the biopsy of the breast lump and it comes back showing cancer, there are three main receptors that we check for: the estrogen receptor, the progesterone receptor, and a receptor called HER2 new, or simply HER2, just for short form. So, and these receptors normally, if stimulated, would cause the cancer to grow. So if you have a estrogen receptor positive breast cancer, then estrogen can stimulate and cause that cancer to grow. Similarly, if you're HER2 positive, certain chemicals will cause that cancer to grow. And we also use this to treat cancer by blocking these receptors or stopping chemicals to reaching these receptors. So, triple negative breast cancer is actually breast cancer that is not positive for any of these three receptors: the estrogen receptor, the progesterone receptor, or the HER2 receptor. It's all of these receptors are lacking in
Okay.
this special type of cancer.
Okay. So we're going to break here. We have a question from one of our listeners, and it's Kovi Dupuy 2020 to the lab for testing. And I am assuming she's asking if the patient would have to proceed to the lab for testing.
No, when we take the sample, when we do the biopsy, we get a sample of the breast tissue. So we send that tissue to the lab, but the patient doesn't go to the lab. The tissue that we take out from the biopsy goes to the lab.
Okay, great. Excellent. So we've had our biopsy done. We've confirmed that there is cancer based upon a lump in the breast. What are our options surgically? Um, is it that we go automatically to removing the entire breast? Can we just remove simply a lump in that breast? Or do we watch and wait? What do we do?
Well, we normally wouldn't watch and wait.
Absolutely.
After we have after we will offer some type of treatment once we have confirmed that there is cancer in the breast. Sometimes we will have to do genetic tests to help guide this treatment, because some patients are more predisposed to cancer because of their genes. So we sometimes test these genes to make sure the patient is not one of these patients. So if the patient is average risk, the genes are not showing any predisposition, then the surgery, and we need to discuss it, of surgery on the breast, looking at surgery on the breast, and then surgery on the armpit. This is where the lymph nodes are, where cancer can sometimes spread. So when we look at surgery on the breast, it's quite rightfully you said we can do a lumpectomy, or what we call breast conserving surgery, where we take out the lump of an area of surrounding normal breast tissue. So we want to get what we call clear margins. So we take out the lump and the area surrounding normal breast tissue. Or if you are not doing a lumpectomy, some patients would opt to have a mastectomy, which is to remove the breast. And whenever we think of mastectomy now, we always have to think of reconstruction of the breast. And
Absolutely.
reconstruction, yes. And reconstruction can involve using the patient's own tissues, or we can use an implant to reconstruct the breast. Unfortunately, some patients are not candidates for reconstruction because they have many comorbid illnesses. It would have made the operation too long. But even in those cases, sometimes we may have to do it in a second operation. But it's always in our mind to think of reconstruction whenever we think of mastectomy. And the good thing about it is, once if you do surgery, either breast conserving surgery and mastectomy, they have the same overall survival. The only thing is that if you do breast conserving surgery, then you will have to give radiation therapy as well. But the
Uh,
two of them will have the same survival. So it's not like if you take off your breast, it's going to make you live longer, or if you if you do the lumpectomy, it's going to shorten your survival. The two of them have been shown to be equally efficacious or effective in treating breast cancer. After
okay.
that, we look at. Mhm.
Go ahead, go ahead, go ahead.
No, I was saying after that, we look at surgery on under the armpit, or what we call the axilla. And this is to look to see if the cancer has spread to the lymph nodes or not. So we would normally want to sample the lymph nodes under the axilla in the armpit to see if the cancer has spread. If the cancer has spread, or we can detect that before the operation, we'll do a more extensive sampling, what we call an axillary dissection.
Okay. I like the fact that you did make very clear mention of the importance of removing some normal tissue from around that tumor. Can you explain why it is important to do that? I know that persons may be concerned, but why are you also taking out my normal breast tissue? But explain to us why it's really important that if you are going to do a lumpectomy, that some of that normal tissue is also removed.
Right? We would take some normal tissue, and it's just a minimal amount, but we want to have what we call clear margins. We do not want to leave back any of the cancer once we operate on the patient. So we always want to take the lump out and a little area of normal tissue surrounding the lump. So we know that we are not leaving back any focus of cancer in the patient. Because when you leave back a focus of cancer, that puts you at increased risk of recurrence again in the breast. So that's why we would try to get an area that is normal along with the area that has any cancer when we do this operation.
And this is also confirmed in the lab that you do have clear margins so that you as a surgeon, you are completely comfortable that you have gotten the
Yes,
entire malignancy. Great. So,
exactly. All the time, we send the samples to the pathology lab for confirmation.
great.
And
We have
sometimes if
enough.
you don't get clear margins, go
Mhm.
on. Yes.
Go ahead, go ahead, go ahead, continue.
No, I'm just saying if you don't get the clear margins, if you don't take enough of the normal tissue size, we will have to go back and take a little bit more.
Okay. We have another question here before I go on. If the patient gets a mastectomy, would they require radiation therapy afterwards? And is there a difference between radiation and chemotherapy?
Okay. Let's start with the first one. Normally, after mastectomy, radiation therapy is not needed except in certain circumstances. In cases if the tumor is aggressive, if you still have margins involved, so in cases where the tumor invades into the muscle, you may still need to do radiation therapy. Also, if you have more than 3 axillary lymph nodes involved, even though you have done a mastectomy, then you may need to do radiation therapy as well. And in terms of the second question, radiation therapy is a little different from chemotherapy. So radiation is using X-rays. It's similar to when you do an X-ray of your hand, but it's just many more X-rays, thousands more, concentrated and focused on the breast or on the armpit to kill any cancer cells. So that's radiation therapy, the use of X-rays, thousands of them concentrated and focused on a specific area, compared to chemotherapy, which is usually medications or drugs, chemicals, either intravenous into the vein or by mouth that we give to kill cancer cells. And radiation and surgery work locally at the site of the breast or the axilla, the armpit, where we apply them. But chemotherapy works throughout the whole body where you take the medication. So it kills cancer cells throughout the whole body.
Okay, we have another question. Good evening. This is from Corporate Ras. Good evening. What are the
Good
risks
evening.
of breast cancer in men? As I have heard that it can occur in men as well.
Okay, so the risk of average risk for breast cancer in women is about one in eight, approximately 12.5%. The average lifetime risk for women, and for every one woman that gets breast cancer, sorry, every 100 women that gets breast cancer, there'll be approximately one man. So it's approximately 100%, 100 times less, sorry, for men.
Okay.
But men can get breast cancer, and they can have some of the same signs that women would have: lumps in the breast or lumps under the arm, discharge from the nipple, rash to the nipple, and even the nipple changing its shape and orientation. That's a very good question. Men can get breast cancer, even though not as commonly as women.
Great. So I'm going to move on now because you started to speak just now about the use of chemotherapy and radiation. And a lot of persons are quite concerned about taking in of drugs, the bad effects that sometimes some of these drugs, they may have heard persons um, relaying to them that these drugs may have, the nausea, the hair loss. Can you tell us a bit more about the chemotherapy and the radiation that is possibly used, and generally why we want to use that in terms of, as you started to allude to, the prevention of the spread of, or rather to aid in the killing of some of those cancer cells that may have gone throughout the body. And this is a segue into opening up to metastatic breast cancer.
Yes. So the chemotherapy drugs, they have a bad reputation. I know patients are usually concerned about the hair loss. Sometimes the hands and the feet would become darker in pigmentation. But we always have to look in medicine and for the chemotherapy drugs and any drugs that we give, what the risk versus the benefits. So the side effects for some persons can be quite unpleasant. That is without a doubt, and we appreciate that. But we have some patients with locally advanced breast cancer or metastatic breast cancer, which can spread or has spread throughout the body, and we need to treat that systemically. And we can't cut out or try and take out every place that the cancer has gone or could go or give radiation. So then, in a case like that, we think that chemotherapy would definitely benefit these patients. The benefits would definitely outweigh outweigh the risks.
Hmm. Hmm.
Yeah.
And what is the, do you have any statistics on generally how many persons are managed successfully with um, chemotherapy and radiation therapy adjuncts?
The actual survival rates, you mean?
Yes, please.
Right. So in terms of stage one disease, that is the early stage breast cancer. Approximately 95% of these patients would be alive at five five years. How many of them exactly would get breast cancer? Probably about 50%, 50 or 60%, or even more. The stage three and stage four cases, majority of them, not all of them, once they're fit and healthy and can sustain the therapy, would get chemotherapy, but the survival rates are a little lower. I think it's about 15% for stage four and about 72% for stage three, roughly.
Okay. And when you say stage four disease, we are talking about the.
Right,
Go ahead,
right. Cancer
explain.
has spread. Right, stage four disease is cancer has spread outside of the breast and outside of the armpit that has gone to an organ that's a little far away from the breast. And commonly, the cancer can go to the lungs, it can go to the liver, it can go to the brain, it can go to the bones. So any area that is far away from the breast, we would discuss that as stage four disease.
Okay, we have a caller, someone who's calling in. It's Bootsy. We're going to take that call now. Hello, good
Yes,
evening. You are live.
yes. Good evening, doctors and everybody listening. Um, just wanted to know, would the treatment for men be the same as women? That is mastectomy or removing the lump?
Yes, it will be. The treatment options are very much the same, but you would recognize that the breast in a male is usually much smaller than the breast in the female. So even though a lumpectomy can be done, the majority of men will actually end up with a mastectomy because the breast is so much smaller compared to the female breast. But we will do the same hormone testing. We would then give the same surgery in terms of the checking the nose and the axilla. And then if they need chemotherapy or any additional therapy, we'll do the same treatment for the male that we would do for the female.
Excellent. Thanks, listener, for calling in. So this evening, our episode is entitled You Are More Than Your Scars. So you've had the mastectomy or you've had the lumpectomy and you started to speak about reconstruction. Tell us about the options for reconstruction, both at the time of surgery or for some patients who may not be able to tolerate it at the time of surgery, delayed reconstruction at a later date.
Right. So in terms of reconstruction, you can either use the patient's own tissues, like patient's fat, the patient's muscle, the patient's skin, or you can use tissue that is not from the patient, what we will call an implant. So we'll start talking about the implants first. The implants are usually silicone based, and we can put those in normally in a delayed process. So at the time of the surgery, you would do your mastectomy. Then you will have a space there. We put what's called an expander because you have lost some skin. So we put in an expander and then try to expand the skin and stretch it since you've lost the skin. And then afterwards, we'll come back in a couple of months, then about 3 months or so, and then change that expander out and put in one of the implants which are usually silicone based. The other form of reconstruction, which can be done at the same time of surgery or in a delayed fashion, is what we call autologous reconstruction or using the patient's tissues. And we use various flaps where we take tissue sometimes from the abdominal wall and we use that to make a breast again after a mastectomy. The most common operation that is called the transverse rectus abdominis flap. A big word, but simply called a tram flap for short. And the advantage of it is that the patients also, usually women, will get a tummy tuck because you're taking out muscle and fat from the abdomen to make a breast, so they actually end up with a tummy tuck. So they end up with a flattened abdomen, and you can make a breast. Actually, you're going to a reconstruction. Yeah, we actually have now the field of oncoplastics. So we
Right.
have had women be empowered. They actually have the mastectomy, and they decide, you know what, they actually want to go bigger. So they want to have bigger breasts. So they will get a bigger implant bigger than the original breast. Yes, just because of the patient preference.
Right.
Or we think maybe the breast they may think that they may have what we call ptosis, but what patients will recognize as drooping. So they want a breast lift as well after they have the cancer surgery. And these things are well recognized in treatment of breast cancer. Yes, the plastic surgery aspect of it, or the plastics aspect. We do not compromise the oncological or the cancer aspect, but still we also try to satisfy the woman's desire for a pleasing outcome. And we think that, and we find that that helps with the woman's self-confidence, and you're not so down and depressed that you've had a mastectomy.
Right, because I know that is sometimes a very great concern of females, where they may feel a bit stigmatized sometimes in cases where they have lost the breast. And certainly there is a psychological component to losing their breast where they may feel lesser of a female because they have now lost one of those external characteristics that may define them. And so I am happy to hear that you've spoken about the options that are available from a plastic standpoint. And some women may even welcome it because it's an opportunity to get a tummy tuck where they may have been even struggling with the weight in the midsection, to allow for that better reconstruction of the breast. We have 2 more questions here. What are your views of a double mastectomy if cancer is only in one breast, especially if there's a family history?
Right, that's a very good question. That's actually a question I've been grappling with this today itself. Actually, a patient in my practice, in my public practice. So it's a very good question, and that's a question that the literature has been looking at as well. And I definitely support it in patients who have what we call a genetic predisposition for breast cancer. So that is, yes, they have a family history, but we actually go on and we do the genetic testing, and we do the genetic testing here and see that they have a gene like what we call the breast cancer gene, the BRCA gene. BRCA, and there are two types. So you know if patients have this gene, they have a 60 to 80% chance of developing breast cancer in their lifetime. If they have one breast cancer diagnosed already and they want to have a bilateral mastectomy because they're concerned that they may get another diagnosis, in a case like that, we will actually recommend and support a double mastectomy. Patients know who are average breast, who don't have a genetic predisposition or a genetic leaning to breast cancer, wanting to have a double mastectomy is not something that we would recommend, because like any operation, any procedure, there are complications. And the main complications of mastectomy will be wound infection and blood clot formation at the wound, where it's called hematoma, causing breakdown of the wound. So in those patients, we would not support or recommend it as the first line approach. But as I decided for my patient today, she was keen to have it done. I was going to her previously and give her some time to think about it. But as she wanted to have both off, she was so concerned that she's living with her breast that she may actually develop another cancer in it. So we would offer the risk reducing mastectomy as long as she understands fully it's not indicated strictly based on medical reasons. She doesn't have to have it done. But if that's the only way she would feel comfortable going forward for her treatment, then we will facilitate it for her. But we would strongly counsel against it first and
Right.
recommend more intense surveillance. But then we believe in the woman's right to choice. Oh, sorry.
Go ahead. I was
No,
about
no,
to
I was
ask.
just saying we believe in the woman's right to choose. So even though things sometimes are not exactly substantiated in literature, if the woman is adamant and they're firm and they understand what the potential complications are and this is the approach that they wish to take, then we will always support and facilitate it within reason.
Absolutely. Especially because it gives a certain level of comfort of mind,
Yeah.
for and the fear that there you may have to go through this journey all over again. Um, we have a few questions. The questions are coming in quite nicely this evening. Good evening. Is breast cancer more aggressive in men? And do men tend to present with a lump earlier than women?
Well, it depends on the type of breast cancer. We see triple negative breast cancer more often in men sometimes, and triple negative breast cancer tends to be more aggressive. So it depends on the type of breast cancer the patient has. If the patient has the similar hormone receptor positive breast cancer, what we call the estrogen receptor positive to women, then it may not be as aggressive or more aggressive in a man than it would be in a woman.
Right. And that's certainly
That's the
because
first part.
generally men don't
Mhm.
have as much estrogen. Um,
Right. And
and do
then,
they tend to present earlier? That was the second part of the question.
well, remember the male breast is smaller, so I would not say it depends also on but men tend not to do breast exams. So
Right.
the problem is with men, the male breast being smaller. I'm not sure if you mean early in terms of the time for having a lump or in terms of the stage, because since the breast is smaller, it may be at a more advanced stage because it's a more likely infiltration into the muscle just because the breast is smaller.
Right.
But men tend not to do breast exams as often as they should. But I can say definitely conclusively it tends to present later just because they're a male. That's a very good question, I would say.
Okay, great. We have another question, which was actually leading right into what I was going to talk about next. Because for our image for today's flyer, we actually had a scar that was tattooed. And this listener is actually now asking about, so what happens to the nipple? Because you spoke about the skin that you're going to expand or you're going to use tissues from another area of the body.
Right.
But what a lot of women are concerned about still having that nipple, that natural look. So tell us about the nipple, and if they are cut away with the breast, how do you reconstruct them? Because that is happening in the field right now. So tell us about that.
Right. So I will say, first of all, sometimes we are able to spare the nipple, what we'll call a nipple sparing mastectomy. So we would not remove the nipple. We can do the surgery, the same mastectomy, and leave the nipple intact, a nipple sparing mastectomy. Then we could go on and put our expander and then put the implant as well. Following that, and the nipple, the same nipple that the patient was born with and grew with, is there. The only proviso is though is at the time of surgery, we would take a little piece from the bottom of the nipple to make sure that it is free of cancer. Because remember, as I said, the cancer operation takes priority, but we also try to aim for a pleasing outcome. If we
Right.
have a case where we have to do uh, operation to remove the nipple, then the options for nipple reconstruction are many and various. Yes, but even before we get to reconstruction, some persons opt just to have tattooing.
Mm-hmm.
Yes, what's the 3D? It's called three-dimensional tattooing. So it will have the appearance, the shading of a nipple and an areola, the dark area around the nipple. And looking at it, unless you're close up and touch it, you will not even realize that it's not a real nipple.
Right.
Yeah. Apart from that, you can use the same skin from the new breast to reconstruct the nipple. We make flaps and we mold it and do therefore different things to give the appearance of a nipple. The only drawback in these cases though is this nipple may not have the sensation, the same sensation as the native or the original nipple.
Right.
And for women who have certainly protuberant nipples, we can
Mm-hmm.
do a nipple transplant. We transect the nipple. We will move part from one breast to the next breast. So they will lose some protuberance, but they will have the appearance on the side that had the procedure of a
Right.
nipple. But they may also lose the sensation.
Okay. All right. And what about options where some women may not wish back a nipple, or they may not wish reconstruction in the fashion that you have stated previously? Would you recommend, or what are your thoughts on tattooing? Like, for instance, the image that we saw, and in terms of especially the psychological component for females.
Right. I've seen some patients. I think here in our local setting, I think we have a fear of needles, so we don't see many patients getting tattoos after mastectomies. But I know in the north they do that often. It's a way of empowering the woman. It's basically to say, I fought this thing, I fought this cancer, I beat it. This is my scar, and this helps sometimes have some quite beautiful and elaborate tattoos on the
Right.
chest area after the surgery. So I think it's really very empowering for the woman. Is they have it's a woman's body, they're taking charge, and
Right.
it's another option.
Okay. Very good. Because I mean, certainly a lot of persons sometimes delay to present to the doctor for surgical management of breast cancer because they're very scared about the potential options, especially from a surgical standpoint. Generally, when would you say that a patient should present? Because sometimes, unfortunately, we have seen patients who may present with an ulcer, as you said, or what we may call a tumor breast. Um,
Hmm.
and I want you to really explain the importance of why we really shouldn't delay the management. What is the benefit for that patient?
Right. I think they should present, and I'm a proponent of screening. So for women over the age of 45, for sure, I think they should be looking to do their mammograms yearly. Some recommendations, some institutions recommend that you do it from the age of 40. And what that does for us is it helps us to detect lesions sometimes before long before the patient can even feel them.
Mm-hmm.
So definitely, we want to get these patients before they even have a lump. But if they are not doing the screening or for some reason they have done it and then they've fallen off and they feel a lump in the breast, we want to see them the next day or as soon as possible. And the majority of lumps in the breast, over 80%, I think up to 90% of breast lumps are actually not cancer. But that is usually a woman's greatest fear, that this is a cancer. So let me not go. Maybe if I not go, it would go away. It would get better. But no, we want to see them as soon as possible. The earlier we see them, most often, the more options we have and the better the survival in most cases, the earlier we see these patients. So we want to see them at detecting, having cancer detected at screening. before they feel a lump. But if they're not getting that screening for whatever reason, we want them to come as soon as they feel the lump. Bearing in mind that 90% of lumps felt in a female breast are not going to be cancerous.
Okay, we have a call again from one of our listeners. We're going to take that now. Good evening, caller. You're live again. Go ahead.
Yes, again, good evening. Just a question. What advice would you give a young lady who had a double mastectomy? And I'm thinking about a double mastectomy, about having children, and I'm thinking breastfeeding.
Right. She's had a double mastectomy.
Yes, and
Yeah.
still in childbearing age. And
Yes. She
what
can have
advice would
children,
you give her?
definitely, once the ovaries are functional, but unfortunately, she may not be able to breastfeed if both breasts have been removed. But still, she can bond. They have to use bottle feeding, but she can still bond with the child.
And certainly there are units where the female can actually attach to the chest that can assist with that. It does, as you correctly said, does assist with the bonding, but would also allow for the mother to insert, as you correctly said, breast milk to assist that bonding. True.
The units for the breast, is it like a prosthesis you're saying? I'm not, those
Yes.
ones I'm not familiar with.
Yes, please. We have another
Okay.
question here. Many women complain that mammograms are painful and will avoid doing them. Something that I quite often hear in my practice. Is there anything that can be done to make them less painful? Or I will add my own question onto that. Is there another option?
Well, first question, is there anything to be done to make them less painful? And some women have more sensitive breasts than others, and it will be some discomfort or pain. But there is nothing that we can do specifically, no medication to give. But I still advise my patients to go and have a mammogram done. Yes, it may last for 5, 10 minutes, but the information that we can get from it is so valuable. It's so much information that I would advise them to do it. In cases where the women are adamant that they would not do the mammogram because it's painful, then we will counsel them about doing at least an ultrasound. But then you will not get the same information for the ultrasound that you will get for the mammogram. The mammogram sometimes sees lesions, what we call calcifications, which have increased calcium. You can see them show up on the mammogram that you may not see on the ultrasound. There's a lot of interest also in breast MRI for screening. But the problem with breast MRI is so sensitive. It picks up a lot of lesions that mammogram and ultrasound will not see and sometimes will not turn out to be malignant. And whenever you do breast MRI, you need to do a biopsy. Because you see the lesion, you have to biopsy if it's suspicious. So breast MRI is not recommended for routine screening, only again for patients who are high risk for breast cancer, those who have certain genetic abnormalities like the BRCA1 and 2 genes, who have not completed their family and still want to have a family and breastfeed, then we would recommend the MRI from the age of 30. But it's not recommended for routine screening. So to sum it all up, we would plead with you to please do the mammogram. We think the benefits again outweigh the discomfort. But if you want to do the mammogram or you can't do the mammogram, at least do the ultrasound. And for persons who are extremely high risk, then breast MRI comes into play. But if you
Okay.
understand that, we'll have to go ahead and do any biopsies guided by the MRI.
Right. We have another question here. At what age should women stop having mammograms, if at all?
Right. That's a good question. The normal age that women would stop having is recommended is at the age of 75, or if the patient develop other conditions such that the woman's life expectancy is less than 10 years. So if she just may develop another cancer that has spread, or if she has such bad heart failure, we do not anticipate because of the progression of her disease that she will not survive for 10 years. Then at that time, we would stop doing the mammograms. But if
Right.
if you have a patient, it's a very individualized decision again because the guidelines say 75. But you see a fit patient who is 75, minimal comorbidities or minimal illnesses, such as say who is active and doing well, and she wants to do her mammogram, and she will accept treatment if a breast cancer is found, then you really have to have that discussion with her and go ahead and do the mammogram
Right.
if she's been doing them up to now then. Yeah.
I want to ask, will breast augmentation increase the risk of that lady getting breast cancer?
No, breast augmentation would not increase the risk of breast cancer. As you think of it traditionally, if you're talking about implants, you're
Yes.
talking about implant, if right. If you're
Yes.
talking about implants, right, not of getting breast cancer, but implants have been associated with a certain type of lymphoma that is associated with them, that comes with them. And it's seen in about 1 in every 30,000 women who get implants. So now, whenever we are putting in implants, we actually have to let patients know about this risk. It's relatively small, but we still have to let them know that 1 in every 30,000 women who get implants are at risk of a lymphoma associated with the implant around the in the breast normally.
Right. Um, you stated that they can have either the augmentation and reconstruction process started either at the time of the surgery or they can have delayed reconstruction.
Hmm.
So they've had their surgery. How long after that surgery should they wait before they return to things like exercise? And can they drive? Can they lift stuff that is heavy? Talk to us about that.
Right. So if you have done a surgery in terms of the sentinel lymph node biopsy, which is taking 1 or 2 lymph nodes from the axilla. Yes. After day
Mhm.
3 or so, I would ask them, how you ask the patients to start using the arm again. Try to get the hand above the head, move it around, and do light activities. For axillary dissection, where we're taking out more nodes. Yes, sometimes we would leave a drain. Oftentimes we will leave a drain in, so we find that women may have some discomfort from the drain. But still, I would encourage them after the first 3 to 5 days to try to move the hand, get it above the head, and so forth.
Mm.
And we try to get the drains out by 2 weeks at the latest. Normally 7 days, because the drain is a foreign body, is associated with increased infection. And then we
Right.
start them again from a graduate from physical therapy, either formally or informally, using the hand again, and then graduate to try to get them back up by at least 6 weeks, doing everything that they were doing before the surgery, once they're not having any side effects from the surgery. But some
Mm.
will get there a little faster, some will get may take a little longer than 6 weeks, but we would encourage them to be active. And there's no, after the 6 to 8 weeks, there's no restriction on activities.
Okay, great. Can they drive
Yes,
in that in
after
that
once
in
the
that
drain,
first 6 weeks period?
yes, once the drains are out,
Mm-hmm.
within the first week, they should be able to drive once they're not having too much discomfort. And definitely after 2 weeks, they should be in a position to drive. Yeah.
Okay. And also in terms of revisions, how often, what are some of the complications that women may have after having reconstruction, if they have any?
Right. In terms of the complications after reconstruction, the main complications have to do with implants. Sometimes you can get infection because the implant is a foreign body, and this
Mm-hmm.
can be delayed. You can get implant rupture, so you get leakage of silicone, and this forms a capsule around the implant, and we need to take out that implant and revise it and put a new one. Sometimes we get deformities because of the implant changing position, because women tend to lose mass in the breast over time. Sometimes the implant becomes more visible,
Right.
and we may have to go back and revise it. In terms of the reconstruction using the patient's own tissue, where we use fat and muscle, the main complication from that is that we get what we call flap necrosis. Sometimes you can get death of the flap or parts of the flap, and those we have to debride, take away the dead tissue, and then let them heal upon their own. And
Right.
these can result in the cosmetic deformities sometimes that we may need to then address.
Right. When can a person who has had surgery and has a scar, when can they begin scar therapy?
Well, there again is a discussion with their surgeon.
Right.
and see when they're most comfortable. But you're mean in terms of
So we know that sometimes women tend to
you mean
use their different
you mean
creams,
or you
their
mean to
cocoa
like keloids and
butter,
so forth?
cocoa butter,
Hmm.
Moderna, which may be used to try to reduce the appearance of the scar, and yes, even keloids. When can they
Hmm.
start all of that therapy, or when would you recommend that? They really shouldn't go messing with that incision. Mhm.
Right. It's really an individualized decision and consultation with your surgeon because after the first couple of days, first 3 days, 4 days, you don't really want to put anything on your incision, especially if you had a implant inserted,
Right,
because that can increase the risk of wound infection. But
right,
certainly after 2 weeks or so, the skin should be healed or on its way to be fully healed when you look at it with the surgeon. So again, discuss with the surgeon. Some women will heal faster, but around 2 weeks or so, you expect the skin to be healed, and then you could start considering those applications if you are desirous. I know some persons would want to have injections for steroids in terms of keloids and that kind of thing, and they apply the silicone sheets. But
right,
I would say at least 2 weeks, and then more importantly, discuss with your surgeon to see when they are comfortable with the appearance of the wound.
right. Should a woman examine her breast after a mastectomy?
Yes, definitely. She should examine the scar, or if she has a reconstruction, you should still examine the reconstructed breast because there is still a small chance that you can have a new breast cancer or a recurrence of the breast cancer. And you can also examine the other breast if it is still normal because you've had cancer in one breast, the other breast is at the same risk or even higher risk now for having cancer. So the woman should still continue to examine the breast the same as if she had not had the surgery.
And should she perform a yearly ultrasound or any sort of yearly screening on that uh, breast that has undergone mastectomy, or there's not a need to do such?
No, for the breast that's undergone mastectomy, once you've had a mastectomy, you will not need any imaging. But the contralateral breast, or the other side, which has not gone undergone treatment, then that would need imaging as appropriate, either mammogram or ultrasound.
Right. We have another question here. If you normally have lumpy breasts, would it be difficult then to be able to identify potentially cancerous lumps even with a mammogram? And also, should the lumpiness not disappear after menopause?
Right. So even with the mammogram, it can be a little challenging, but it is not impossible. But even before you get to the mammogram, you need to know your breast. So that's why we encourage women to empower themselves and to constantly examine their breasts. Normally, we say to do it at a fixed time. So every 5 days after your period has finished, if you're having your period, or a certain day of the month if you're not having a period. So even if you have lumpy breasts, you know what your breast feels like. You know what is normal for you. So then you know what is abnormal. So you can go to the doctor and say, this is what I've detected. This is not normal for me. I will let you get it checked. And then they can focus in on this on the mammogram. But lumpy breasts, you will have a certain appearance of them on the mammogram or the ultrasound. But then there are certain findings, certain calcifications on the mammogram, the arrangement of the calcification, or if it's on the ultrasound, the blood flow, the edges of the lump, which are worrying. So even if you have lumpy breasts, these worrying signs can still be seen. And those can close in to say, hey, we need to go further, we need to drill down, and we need to investigate more.
Right. And the second question, which is, should that lumpiness disappear after menopause?
Well, it may or may not. It's hard to say. We find if
Mm-hmm.
it's due to fibrocystic changes, which are changes in the breast that happen with the period, you find that after menopause, you may have less of the cystic lesions or the cystic lumps. So they may
Right.
improve after menopause. But it's hard to say. It's not a guarantee. But if it's fibrocystic changes that's causing the lumpy appearance after menopause, it sometimes will, oftentimes should improve.
Great.
And the pain associated with them as well. Hmm.
Right. Dr. Springer, we are starting to come into the closing period of our show. And I'm going to give you this opportunity now to really share some top tips, drill down moments, high yield points for not just our females, but also our males out there, because we do have some men in the audience who are either listening to assist with the management of the females and to assist them in terms of when they reminding their female partners when they should go for the examinations, or for them to also examine their breasts. So, are there any take home points that you want to give our listeners this evening before we wrap up?
Right. So I will say both for men and for women to do your breast examination or chest examination and know what is normal for you. If you find something that is not normal, if you find something that you're concerned about, if you notice a change, even if it's just a rash to your breast and it's not getting better, visit your doctor, visit your general practitioner. Do not delay. Yes, that's the
Right.
first take home point I would say. Even though you may be afraid and you may be worried, that is natural. We are all human, but still, the earlier we deal with things and face them is better than coming later when it becomes a little more challenging. The next day, I would say, and this is more for women, consider strongly have this discussion with your general practitioner about getting your screening test done, your mammograms or your ultrasound. If you have, especially if you have a family history of breast cancer, and you look to do it at least 10 years earlier for the person who was diagnosed in your family with breast cancer, earlier as opposed to later if when you were getting symptoms. If you have a
Right.
preponderance or many people in the family, consider genetic testing to see if you have a genetic predisposition, in which case then we can even consider doing interventions before it gets to the stage of cancer. But act, be aware, and act wisely, I would say. We might have you'll take 1 points. And the surgery for breast cancer, you have many options. It's treatable. I didn't mention it before, but the is safe surgery. The mortality rate is less than 1%. One of any 100 people, less than one out of any 100 people would die from surgery for breast cancer, and it's often day case surgery. You can have your surgery, and you can actually recover at home and follow up with your surgeon as an outpatient. So you don't have to be in hospital, and it's very unlikely that you will have any significant mortality or death from the surgery. And the risk of complications, again, is about 4%, 4 of any 100, and most of them, if not all, are treatable.
Right.
So do not be afraid.
Well, Dr. Springer, I want to say thank you so much. I think our listeners absolutely enjoyed this evening. I want to say thank you, and also thank you to our listeners who participated not only in the message blog, but also in the call in section for this evening. And once again, I encourage you to follow us on both Podbean and Anchor. And next week, we're going to have Dr. Jonathan Noel, who is a urologist who actually deals with robotics. So we've decided, since we did 2 sessions for the ladies and partially for the men, I am going to finish this season with a session for the men discussing the prostate. So Dr. Jonathan Noel, he'll be with us next week. I want to say thank you to everybody. And again, join us next week on First Aid Chats by Dr. G, closing the gap. Good evening, and thank you so much, Dr. Springer.
Good evening. Thank you very much for having me.